When murders in Baltimore dropped to a 70-year low, the city didn't just arrest its way out of the problem. Writing in Vox this week, Bryan Walsh traces the shift to a specific tactic, treating street violence exactly like an infectious disease. Something interesting emerges when placing that victory next to a Stat News essay published a day earlier by Ali Ahmed, Jeff Taylor, and Jeff Barry. They look at the opposite end of a medical triumph, warning that an actual cure for HIV could trigger a bureaucratic disaster by stripping long-term survivors of the benefits keeping them afloat. Together, these pieces capture the unexpected edges of a public health breakthrough. In an article published just yesterday, Bryan Walsh looks at a surprising national mystery. America's murder rate has fallen to a 70-year low, yet experts struggle to explain why. Walsh points to Baltimore for concrete answers, showing how the city drove down homicides by treating gun violence like an infectious disease. Notice the exact message outreach workers deliver when they knock on doors: a blunt combination of police surveillance and immediate housing support.
A few things are certain in life: death, taxes, LeBron James playing professional basketball, and Americans' belief that crime is getting worse. Since Gallup began asking about national crime in 1989, a majority of respondents said they thought crime in the U.S. was higher than the year before in every survey year except 2000, 2001, and 2025. Even in that last year, 49% still said more crime was happening. It's perhaps the archetypal example of negativity bias, the mental habit of giving more weight to bad news than good. America's murder rate hasn't been this low in 70 years. The country's murder drop is still a mystery. Baltimore may help explain one piece of it. Last week, the FBI put some numbers on just how big that bias is. The American murder rate, which peaked in 1980 at 10.2 per 100,000, fell to an estimated 4.1 per 100,000 people in 2025, matching the rates recorded in 1955 and 1956 for the lowest ever measured in the country. The violent crime rate, murder, rape, robbery, and aggravated assault, fell 9.7%, the largest single drop since J. Edgar Hoover was running the Bureau in 1936. That much is known, but what's not known for sure about the crime drop is almost everything else. Adam Gelb, who runs the Council on Criminal Justice, says that there was no single or easy explanation for the historic lows, while Jeff Asher, the analyst who spotted this decline before nearly everyone else, agrees. For every leading candidate, federal pandemic spending, some normalization after the 2020 social collapse, better violence prevention, even the decline of drinking, there was a corresponding hole. But there is one American city where researchers can point to a specific program, measure what it did, and put real numbers on it.
And it just happens to be the city that spent 50 years and 5 award-winning seasons on HBO as America's shorthand for murder. What Baltimore did. Baltimore recorded more than 300 homicides a year for most of the last decade, and more than 200 for most of the past half-century. In 1 month, July 2015, 45 people were killed, an astounding figure for a city of just around 600,000 people at the time. But Baltimore finished 2025 with 133 homicides, the fewest since 1977, and about 60% fewer than in 2020. Through the first 8 months of this year, the city has seen 60 murders, and the police commissioner's target is to stay under 100. What caused this? 3 things at once. Baltimore Mayor Brandon Scott's group violence reduction strategy identifies the few people most likely to shoot or be shot, 2 groups that heavily overlap, and sends people to their doors with 2 messages. You are on our radar, and here is housing and job training. Separately, the longer-running Safe Streets program puts outreach workers with real street credibility between disputes, aiming to interrupt them before they become shootings. That's the harm reduction element. There's also a tough-on-crime component. The state's attorney office says it has secured 2,129 convictions since 2023 across several gun-related violent crime categories, with over 1,700 of those defendants incarcerated. Meanwhile, Baltimore's homicide clearance rate reached 60% by mid-2026. Its non-fatal shooting clearance rate was 54%, up more than 12 percentage points from a year earlier. Criminologists have long held that the certainty of being caught deters criminals more than the severity of the sentence, and more successful shooting investigations are a common thread where violence is falling around the country. How do you tell whether a program worked, or whether a city just got lucky? Drug trials get a control group, cities don't. Baltimore got one almost by accident. The strategy launched in the city's Western District in 2022 and nowhere else, which left the rest of the city as a comparison. That's what a team of economists and criminologists used. They measured the Western District against Baltimore neighborhoods that hadn't started the program yet, and over 18 months, the number of people shot there, fatally or not, ran about 30% below that stand-in. Killings alone fell by a similar share, but deaths are rare enough that chance couldn't be ruled out. Police made no more arrests than before. Arrests for serious violent crime rose 81%. A second, looser test set the whole city against a composite of other big American cities and put Baltimore's murder rate about 25% below it. The authors are careful with that one. Too much changed in Baltimore at once to say how much the strategy was responsible for. Murder is contagious. Baltimore's success is built on two ideas, and they came from two very different places. The first came from a doctor named Gary Slutkin, who spent the 1980s and early 1990s fighting tuberculosis in San Francisco, cholera in Somali refugee camps, and AIDS across Africa. He came home to Chicago in 1995, a year the city recorded over 800 homicides. Key takeaways. Americans have told Gallup crime is getting worse in nearly every year since 1989. In 2025, the U.S. murder rate fell to 4.1 per 100,000, tying 1955 and 1956 for the lowest ever measured, and violent crime dropped 9.3%, the largest single-year fall since the FBI began national estimates in 1936. Nobody can say why. Federal pandemic spending, the unwinding of the 2020 collapse, violence prevention programs, Americans drinking less. Every leading explanation has a hole in it. Baltimore is an exception. Because its group violence reduction strategy launched in one police district first, researchers could measure it against the rest of the city. Shootings there ran about 30% lower, and police made no more arrests than before. When Slutkin examined the city's shooting maps, they looked familiar, clustered in space, clustered in time, and spreading case to case. Murder resembled the outbreaks he used to fight. Slutkin reasoned that the way to treat violence was to treat it like cholera. Find the people most likely to transmit. Interrupt the transmission. Change the conditions that let it spread. Slutkin built the model into a program called Ceasefire, now Cure Violence Global, and its Baltimore descendant is Safe Streets. The second idea came from a criminologist. David Kennedy, working in Boston in the 1990s, found that 61 gangs with about 1,300 members, under 1% of the city's young people, were tied to at least 60% of its youth homicides. Get those people in a room with police, prosecutors, and community elders, tell them plainly what comes next, and the shooting slows down. That approach is called focused deterrence. Baltimore's group violence reduction strategy is a version of it.
To see how it works over a longer period of time, take a trip across the Atlantic to Glasgow in Scotland, which in the early 2000s was considered the murder capital of Europe. In 2005, in the midst of that wave of violence, Glasgow's Strathclyde Police established a violence reduction unit that operated with a basic thesis. Evidence shows that violence can be prevented. Among other interventions, the unit sent trauma surgeons into schools to describe what a blade does to a face, and stationed outreach workers at hospital bedsides to reach victims in the vital hours after an attack, the moment when retaliation can still be stopped. In 2024-25, Scotland recorded 45 homicide victims, the fewest since comparable records began in 1976, and down from 96 2 decades earlier. Every case was solved. Pull the handle. So we have clues to why crime has dropped so much, but not clear conclusions. As successful as Baltimore's group violence strategy has proved, a 2023 study of a similar street outreach effort in Boston found no effect whatsoever. And the latest evaluation of Baltimore's own safe streets, 11 sites, each measured against a stand-in version of the same neighborhood without the program, produced numbers that sound terrific, but settle very little.
youth homicides down 42%, and youth shootings down 21%, but neither is strong enough to rule out chance. And while some sites saw youth homicide fall by as much as 100%, 2 sites saw it rise by 42% and 89%. Some experts, like the UC Irvine criminologist Emily Owens, argue the crime decline has been so widespread and similar, big cities and small, red and blue governments, that the true cause is some larger social change rather than what any one city is doing. Nor can we be sure the fall will continue.
Billions in federal pandemic relief money has supported many of the programs that have worked well in places like Baltimore, and that money is already running out. But we can identify one reason why it happened and learn from that success. As it happens, Gary Slutkin was not the first doctor to look at a map of the dead and see a pattern in it. In September 1854, a cholera outbreak was killing hundreds of people in London's Soho district. A doctor named John Snow had mapped the outbreak and saw the dead were clustered disproportionately close to the district's Broad Street water pump. Snow had a theory that water was connected to the disease and convinced a Soho parish board to remove the handle of the pump. Nobody in Soho at that moment could have told you what caused cholera. It would only be 29 years later that someone would definitely identify the responsible pathogen, and in doing so, explain why Snow's intervention worked. But the explanation could wait. The dying stopped that month in Soho, just as it is stopping in Baltimore and around the U.S. today. And that's what counts. A version of this story originally appeared in the Good News newsletter. Sign up here.
When outreach workers knock on doors in Baltimore to interrupt a shooting, they are treating murder like an infectious disease. Bryan Walsh shows how adopting that public health model helped drive a historic drop in violence. It feels like a clear victory for medical thinking. But what happens when an actual medical victory arrives? Up next, Ali Ahmed, Jeff Taylor, and Jeff Berry look at the push for an HIV cure, and they see a looming administrative disaster. Notice how both pieces center on the safety nets built around public health. Where Walsh focuses on how a new intervention can save lives, Ahmed, Taylor, and Berry worry about what happens when a system suddenly decides its job is done. They point out that long-term HIV survivors rely on housing assistance and disability income just to survive. If a biological cure is announced, paperwork systems might instantly cut off those benefits, ignoring the lasting physical damage from decades of illness. Read alongside Walsh, their warning adds a sharp twist to the idea of a medical breakthrough. Defeating a virus is only half the problem. The other half is surviving the bureaucracy that follows.
A cure for HIV would be one of the greatest medical achievements in modern history. But the day a cure is celebrated could also be the day some long-term survivors are told they no longer qualify for the benefits and services that have helped them stay alive. In our work with long-term survivors, community advisory boards, and discussions about a cure, we have heard a recurring concern that deserves far more policy attention. What if a cure, or durable control, where the virus remains in the body but at such low levels that it doesn't cause problems and cannot be transmitted, is treated as proof that support for patients is no longer needed? That fear comes from people who want a cure, but are also wary about what can happen when administrative systems move faster than common sense. HIV cure research has advanced enough that policymakers should prepare now for its social and administrative consequences, not only its scientific promise. Over the past decade, the field has moved from theory to increasingly sophisticated immunological, gene-based, and combination strategies. A handful of cases have shown that it may be possible to rid the body of HIV, or to reach a point where the virus stays dormant without daily medication. Rare proof-of-concept cases have shown that durable control without ongoing antiretroviral therapy may be biologically possible, even if those approaches are not scalable for most people living with HIV. That progress makes one policy question urgent. If cure or durable control becomes possible for some people, what happens to the benefits and services on which many people with HIV still depend? Without safeguards, scientific progress could trigger a benefits cliff. People with HIV could face reassessment or loss of Medicaid, Medicare, Ryan White HIV/AIDS program services, AIDS drug assistance program support, disability income, housing assistance, and other essential services if administrative systems interpret cure or durable control as evidence that need has ended. This could happen in many ways, including through routine reviews for these programs, such as Medicaid renewals or housing program reviews, or reported changes in medical status or insurance coverage. In a policy environment already marked by paperwork burdens, delayed renewals, and administrative churn, that risk is not abstract. This issue matters for all people with HIV who rely on safety net programs. The Ryan White HIV/AIDS program alone served more than 600,000 people with HIV in 2024, representing more than half of people with diagnosed HIV in the United States. But it is especially urgent for long-term survivors. In the U.S., nearly half of people living with HIV are age 50 or older, and roughly 1/4 of that group, about 300,000 people, are long-term survivors who were diagnosed before effective antiretroviral therapy became widely available. Many endured toxic early regimens, profound loss, persistent stigma, interrupted employment, and years of fragmented care. Many are now aging with multiple chronic conditions, disability, trauma, and ongoing financial precarity. For them, cure may reduce treatment burden, but it does not erase the long-term consequences of having lived with HIV. That distinction is the heart of the problem. A change in viral status is not the same as restored health, work capacity, economic security, or social recovery.
If programs rely too narrowly on HIV diagnosis as a proxy for need, then a person who achieves durable control could be treated as though support is no longer necessary, even when disability, chronic conditions, and social vulnerability remain unchanged. The concern isn't new. Community discussions about it intensified after Timothy Ray Brown, the first person documented to be cured of HIV, later faced housing difficulties. His experience became a cautionary example for many in the HIV community. Scientific success does not automatically translate into social or economic security. Other areas of medicine show why this concern is not hypothetical. For years, many people who qualified for Medicare because of end-stage renal disease lost Medicare coverage 36 months after a successful kidney transplant, even though they still needed lifelong immunosuppressive medications to keep the transplant functioning. Congress later created a limited Medicare immunosuppressive drug benefit to address this gap. But the example is instructive. When policy treats a biomedical milestone as the end of need, patients can face new risks precisely because treatment succeeded. Cancer survivorship offers a related lesson. The completion of active treatment does not necessarily end financial hardship, disability, or the need for ongoing support. The consequences would not be evenly distributed. They would fall hardest on people already navigating intersecting inequities shaped by age, disability, poverty, housing instability, racism, gender inequality, and stigma. Black and Latino communities, women aging with HIV, transgender people, and others facing structural disadvantage are disproportionately represented among those who rely on public benefits and safety net services.
A cure policy that ignores these realities could widen disparities instead of reducing them. This is also a matter of trust. Long-term survivors remember when policy lagged behind the epidemic, and when access to treatment, care, housing, and dignity had to be fought for. If an HIV cure is celebrated while essential supports are reduced or withdrawn, many survivors will hear a familiar message. Progress is valued, but the people who lived long enough to reach it are expendable. That would not only be unjust, it would corrode the community trust that HIV cure research depends on to move forward. The practical consequences could be significant. Some long-term survivors may reasonably hesitate to embrace cure-related interventions if doing so could jeopardize the services they rely on. When policy creates the perception that getting better leads to losing support, people avoid getting better. Benefits continuity is therefore not just a bureaucratic detail. It is a precondition for cure research to succeed. Policymakers should act before cure-related classifications become more common, not after people begin losing coverage, housing, or income. Eligibility for health coverage, disability support, housing, and related services should remain anchored to persistent need, not to HIV status alone. Federal and state agencies should work with communities and issue clear guidance that cure or durable control must not automatically trigger loss of eligibility, and systems should provide rapid review pathways and coordinated reassessment practices across Medicaid, Ryan White, and related programs. Long-term survivors embody both the devastation of the early epidemic and the gains made possible by decades of scientific, clinical, and community effort.
They deserve to see a cure, not fear the losses it might bring.
A quiet street corner or a cleared virus in a bloodstream might look like a clean finish line, but a breakthrough is rarely that simple. In Baltimore, mapping bullets like an infection saved lives. Yet for HIV survivors, an actual biological cure threatens to rip away the housing vouchers keeping them indoors. The medical model works, but the social fallout remains. What is left to sit with is the reality of the aftermath. When a long, devastating crisis finally ends, who catches the people left standing in the wreckage?